Everybody, and welcome to the Hughes Clues Stroke and Acute Intracranial Problems. And these principles that I'm going to talk about on these first few slides are really things that you should think about with any type of intracranial problems, regardless of what the problem is. And when I think of intracranial, of course, I think about things inside the head or inside the skull. And to my mind, the skull is like a box, a very hard, rigid box. And inside that box are three things: the brain, the CSF, and the blood. And if you look at this pie chart, you can see that the brain occupies a specific amount of space, the majority of the space inside the skull. And then the other objects that occupy space inside the skull are the CSF and the blood, and they each have, of course, their own allotted space. And because the brain, the CSF, and the blood are enclosed within this box, in this rigid box, there is pressure that is generated inside the space, and that pressure is known as intracranial pressure. So what would happen to the intracranial pressure if, for example, that something happened to the brain that caused the brain to swell or to have edema, and then it occupied more space than what it was allotted? And I want you to provide or think about a specific value. And whenever I ask questions, if you want to play along, you can pause the recording and try and think about it on your own. Otherwise, just keep going and just listen to the recording. Again, what would happen if the brain were to swell? Well, the intracranial pressure would go up or increase, and normal intracranial pressure is anywhere between 5 and 15. So if the brain were to swell and occupy more space, then the intracranial pressure would be higher than 15. So what is the significance of that? Well, the other concept that you have to understand is that brain cells must have oxygen. Anaerobic metabolism is not an option for the brain. So if the brain was without options, or oxygen, so how long could it do okay or do well? And when we talk about oxygen deprivation, let's identify a specific mechanism that can cause brain swelling and edema and increasing ICP. So let's talk about the first question, and that's the fact that brain cells must have oxygen. And so what happens if a brain cell is without oxygen? So we go back to patho. I know this is annoying, but you have to kind of understand and get what's happening to the underlying problem. And if a cell, any kind of cell, is without oxygen, then that will decrease the ATP production, and ATP is the gasoline or the energy source that keeps every cell going. And the majority of ATP is used to work or man the sodium and potassium pump. The object of the cell is to pump sodium out and to pump potassium in. And if there is not enough ATP, then what will happen is sodium continues to stay in the cell. This will cause water to follow and the cell will swell, and then that is what causes the damage and then possibly ultimate destruction of the cell itself. Now, we always think about cellular swelling whenever there's some kind of trauma. If you were hit about the head with a bat, well, then you think, okay, well, cells will swell. But anything that causes the decrease in oxygen delivery will cause this process to occur too. So that would be hypoxia. Now, inflammation or any kind of infection, which is essentially the same thing as an inflammatory disorder, these things will also cause the brain cell to swell. Now, I want you to think about your big toe, and if your big toe was encased within a very tight shoe, there's not a whole lot of space for your toes to move around. And then if something happens, such as a tourniquet was placed on your ankle, cutting off blood flow delivery to your toes, then they would swell. And because they're encased within the shoe, there isn't anywhere for them to go down. So even if the tourniquet was taken off, then blood flow might be limited to getting down into your feet, because when swelling occurs, then that takes up all the space, and then those itty-bitty little blood vessels that are constantly supplying blood to the brain cells cannot do what their job is, and that's to deliver blood. So what I want you to think about is whenever swelling occurs, This can occlude or cut off blood flow to other cells that are in the area of the swelling, and then this continues to go and go and go and so on and so on. So how long can this happen? How long can brain cells do okay without oxygen? And of course, the answer is a very short time. 4 to 6 minutes. And the other organs really can tolerate a low oxygen state better than the brain because they can perform anaerobic metabolism. So your brain has a very short ability to do without oxygen. And once there is no O2, then the swelling process begins. So we've talked about how low O2 states can cause cerebral edema, but let's identify some other causes for low O2 states, some really specific causes. Again, we've mentioned the fact that any kind of head trauma is going to cause swelling because of inflammation. But when we look here, we can also see that any type of issue that stops blood flow to brain cells will cause hypoxia or O2 deprivation of the cell. And when we look here on this slide, on this picture representation, you can see that there's different ways that oxygen can be or that blood can stop flowing. And one of them is what's known as a thrombotic stroke. And thrombotic just means that a platelet plug has occurred at a specific site in the blood vessel. Here it is here. And that has occluded blood from going downstreams to the cells that need it below. Or an embolic is essentially the same thing. It doesn't necessarily have to be platelets, though it can be, but it's some kind of clot, whether it's an air embolus or some other object, and it just means that it traveled from a distant site and then ultimately landed in one of the brain blood vessels and then caused the occlusion. And then there's a hemorrhagic stroke, and this is where the blood vessel bursts, and again, instead of blood going downstream into the brain cell, then we have blood going out side of the blood vessel and not to the brain itself. And then there's other objects such as drowning and infections that will cause the brains to swell. Now, in most circumstances, your brain has the ability to deploy compensatory mechanisms to ensure the brain's survival. And this is known as autoregulation. And what I mean by this is, let's say you were similar to this picture. Oh, I want to be there. And I'm sure you do too, instead of listening to this recording. But if you were standing on your head, then blood, because of gravity, would rush down into the skull, into the brain area. And your brain has the ability to either vasoconstrict, which is what it would do in this instance, or vasodilate, to ensure that there's the constant flow of blood. But for the brain to be able to do autoregulation, number one, the map must be 70 to 150 millimeters of mercury, and the brain must be healthy or not ill. So how do you know, because I've just mentioned that oxygen is so important to the brain, so how do you know if cerebral perfusion is adequate in your patient? Well, you, the nurse, can calculate the cerebral perfusion pressure. Now, there's all kinds of gadgets and gizmos, and I'm sure Dr. Reed will mention them in the course, but for you to really get this, the main thing you need to realize is that you need to kind of figure out, well, how well is my patient's brain being perfused? And there's a mathematical formula to determine whether there is perfusion to the brain. So again, let's review the terms. If I say perfusion, you think that is O2 delivery to the cells, and when it's cerebral perfusion, that is very specifically O2 delivery to the brain cells. And when we talk about cerebral perfusion, the formula is CPP, cerebral perfusion pressure. The formula is MAP minus ICP. And the normal CPP should be somewhere in the neighborhood of 70 to 100. Dr. Reed has identified in the course notes in different places that 70 is the minimum that is accepted as far as she's concerned. You will see in other sources that sometimes 60 is accepted, but this is critical care. Dr. Reed writes the exam, and therefore 70 is the minimum value, 70 or above. Now, how can CPP be calculated? Well, if you notice, it's MAP minus ICP. We can always get a blood pressure and then calculate a MAP, but the ICP is a little bit hard to obtain. And for the ICP to be obtained, the majority of times you'll see a neurosurgeon, that's a special head doctor, that will drill a hole through the skull and put a bolt inside the patient's head. And that tip of the bolt is sitting in the ventricle in the head, and that can measure ICP with the help of this little gadget here that's kind of on the side. When we talk about CPP, we have to do the formula, MAP minus ICP. And if you think about it, you can understand that it's very easy for any nurse to obtain a blood pressure. So where does the MAP come into play? Well, in the hospital, if you use a Dynamap or a blood pressure machine, automatic blood pressure machine, the MAP is calculated for you. In this course, you have to calculate it. So I've placed the formula down here of how you calculate a MAP. And the formula is a systolic blood pressure plus a diastolic blood pressure, plus another diastolic blood pressure. So you could say systolic plus 2 times the diastolic. And then because you have 3 values, systolic, diastolic, then you divide that number by 3. And in our course, whenever there is a blood pressure that's given, you need to calculate the MAP. You don't have an automatic program, you're going to have to calculate the MAP yourself. So when we look at the blood pressure of 120 over 80, we see that that's 120 plus 80 gives us a total of 280. We divide by 3. We have a calculated MAP of 93.33. And then we would further subtract the ICP value, which is 15, and then that would give us the CPP. If you want to play along, pause the recording and then calculate the CPP of the remaining 2 numbers, or the remaining 2 values. So you have a blood pressure of 80 over 40, ICP of 15. If we calculated that, we would get a CPP of 38.33. And then number 3, 120 over 70 blood pressure and ICP of 35. If we calculated that, we would get a cerebral perfusion pressure of 51.67. So looking at these different numbers, you can see that when your patient has a low blood pressure, even if they have a normal ICP, the CPP is markedly decreased. Again, we want a CPP by Dr. Reed's rules of at least 70 or above. So we have a CPP value that is definitely less than 70. Number 3, we have a normal blood pressure and a normal MAP, but the ICP is greatly increased, and therefore the CPP is profoundly abnormal. And of course, this makes sense. If the ingredients of CPP are blood pressure and ICP, either one of those being abnormal will create a low CPP. Again, remember Dr. Reed's rules. The CPP must be equal to or greater than 70. And because there's some confusion with students, because all these numbers are kind of thrown all over the place in different pieces of the notes, for your mind, anything less than CPP is bad. Now, there are different markers that if a CPP is 50, that is considered greatly reduced and brain perfusion, and therefore that's really bad. And then a CPP of 30 and less is really, really, really bad. The bottom line for you is 70 or above is your minimum value. Now, we are talking about stroke and intracranial problems, so let's get into a scenario of how we use all that information, those concepts that we just learned about. So we talk about a 65-year-old who arrived in the emergency department with a complaint of onset of headache, right-sided weakness, slurred speech for the past hour while at work. He denies any previous health problem, though he does not see a physician. He does not routinely take any medications. Note the blood pressure, pulse, respiratory rate, and other vital signs. And then I also placed an EKG strip for you. So what could be happening and what factors place this patient at risk for an event? And really, what event are we talking about? So what could be happening? So you're concerned that blood flow to his brain might be disrupted, because whenever a patient demonstrates or has the signs and symptoms that this patient had, and if you go back to the slide, if you can't remember, we look at the signs and symptoms of headache, right-sided weakness, slurred speech. And so when you're assessing your patient and they have facial drooping, and their arm is not moving in symmetry as evidenced by the terms right-sided weakness, and if their speech is slurred, and we think of fast. And these are the things that really demonstrate or should make you think that either a family member or your patient is possibly having some kind of stroke or intracranial problem. And that is because there is some type of blood flow disruption in the brain. Now, when you think about these signs and symptoms, your head is supposed to think, okay, well, this is a stroke. And I've said to you that there are different types of problems that cause blood flow disruption. So these signs and symptoms of the headache, right-sided weakness, and slurred speech do not really tell you what kind of problem, specific kind of problem that the patient is having. It just really tells you where the problem is, that it's somewhere in the brain and it's somewhere on a specific part of the brain. So it doesn't really tell you what the problem is. So we know that this patient is having a problem with brain cell or brain blood flow disruption. So therefore they're having some kind of stroke and intracranial problem. So what placed this patient at risk in the first place? Well, we look at all of the factors that we knew on that very short history. And we saw that the fact that he was 65-year-old, so as age increases, then that places a patient at risk for a stroke. Hypertension places a patient's risk at stroke. This patient's blood pressure on arrival was 210/110. And if we looked back at the cardiac rhythm, and you know how to read the cardiac rhythm, you could have identified that this patient has atrial fibrillation. And we go back to what we learned in patho, that atrial fibrillation means that the atria are quivering like a bowl of jello, and this can cause blood stasis. And when blood stasis occurs, then thrombi or clots can form. How fast can these thrombi or clots form? Not real fast. It happens over time. Somewhere between 48 and 72 hours is how long it takes for a really organized blood clot to form. So this patient likely has been in atrial fibrillation, or could have been in atrial fibrillation for a while, unless you just happen to have a monitor that you always have on and are carrying around. Patients don't recognize when they're in atrial fibrillation. And any patient in atrial fibrillation, they are greatly at an increased risk for strokes. So as you continue to monitor the patient, what additional assessments are needed? Well, whenever you think of, well, what assessments are needed, and especially when you're asked, well, what should the nurse do first, or what is the most important thing that the nurse do, I want your mind to go to ABC. And you're not unfamiliar with ABC. You've heard about A, airway, B, breathing, and C is circulation. But now we're really going to get into, well, what specifically are we assessing as it relates to each of these three items? And when you have a patient with an airway issue, you really have to assess for swallowing and speech. If somebody has a speech problem and you see, well, you know what, they look like they're kind of drooling, then your mind should immediately go, to an airway issue. Because the cranial nerves rule these things, swallowing and a gag reflex, and the cranial nerves could have a decrease in oxygen, these are the things that you assess as part of the airway assessment. We also look at breathing patterns. In other words, is the patient's rate regular? Is it rapid? Is it slow? And we look for the oxygenation status. What is the pulse oximetry value? And then we look at circulation. What is encompassing in the C assessment or circulatory assessment? And I've got it identified here, blood pressure, pulse, cap refill. Well, what about a neuroassessment? Where does that fall? Well, that's the new letter, maybe, for you, and that's D, and that stands for disability. Notice that the Glasgow Coma Scale, levels of consciousness, pupil reactivity, these are all related to disability. Now, I know that you as the nurse are going, well, gee, you're going to do an LOC after airway? Yes, you are, because that's the rule in nursing. It's A, B, C, and then D. And I know that realistically, many of you are multitaskers and you can assess airway and breathing and other things while you're checking the levels of consciousness, but not on a test. On a test, each issue is a separate thing, and that's what tricks up a lot of students. So here we are, we've got the assessment done of A, B, C, and D. And again, as part of the D, we were going to configure a Glasgow Coma Scale. Notice the Glasgow Coma Scale is only assessing for three things: eye-opening, verbal response, and motor response. And when we identify these things in our patient from our scenario, we see that this patient has scored 4 plus 5 plus 6. So that's 15 points. They have a Glasgow Coma Scale of 15. So what further diagnostic studies are needed to determine the type of brain attack? Again, because we identified in our assessment that this patient had some facial abnormalities, some speech abnormalities, some right-sided weakness, that we figured, well, they have some kind of stroke. We're not sure what kind of stroke, whether it's an embolic, thrombotic, or a hemorrhagic stroke. So what tests determine either of those three things, or which one of those three things? And we know that a CT scan is needed. Now, there's some timing of when these tests should be done. And the National Stroke Scale has identified that the CT scan has to be performed within 25 minutes of the patient's arrival, and then the report has to be generated by the physician. That means it has to be read and reported back that whatever the results are within 45 minutes. And the CT report will only differentiate between an ischemic and a hemorrhagic stroke. So let's look again at the next thing we've identified as abnormal, and that's the blood pressure. So we noticed or assessed that the blood pressure was 210 over 110, and I'm sure that all of you identified, wow, that's pretty high. So what would you expect to do for that value? Would you reduce it very quickly, or would you administer an oral antihypertensive agent? So let's look at some of the goals in preventing further brain damage. So we've already identified that the brain must have oxygen, and therefore the goal is to maintain cerebral perfusion pressure, and that means that cerebral blood flow and therefore oxygen delivery to the brain is important. And we know that CPP is the ingredients of CPP are blood pressure and ICP. So the goal, therefore, would be to manage blood pressure and keep the ICP in normal range. And again, we need to know that because there is a stroke and you have brain cells that are dying or they're definitely ischemic, we know that there can be a loss of autoregulation. Again, the brain is very good at autoregulating its blood flow as long as it's not ill. And when it becomes ill, when there's a problem, then there is a loss, or there can be a loss of autoregulation. So how do we ensure that CPP is at least 70? Well, the next rule of Dr. Reed is that the MAP must be at least 70. So that's two values that are at the 70 range. So the MAP must be 70 or above to ensure CPP, or the systolic pressure must be 90 or above, and these are very, very important. Now, you know that the physician will identify in the physician notes what the parameters are on a blood pressure. So I'm not going to really give you, well, it should be between this or that, because the physician will identify it. You, the nurse, on a critical care test, just need to identify that the MAP must be 70, the systolic pressure must be 90 or above, and the CPP must be 70 or above. And that's all you're expected to know, because parameters will vary depending on the patient and the physician orders. Now, for the most part, in general, Most physicians, most neuro or head doctors will say, you know what, we're going to ensure that the MAP is 130, greater than 130, or excuse me, let me repeat myself, that antihypertensive meds would be given if the MAP was greater than 130 or the systolic pressure is 220. This is not a number you need to memorize because physicians are going to vary and it is going to depend on the type of stroke the patient has. But here's what the goal is, and this is important for you to know, that because of the stroke and the brain cells that are not operating the way they should be, and therefore autoregulation is kind of messed up, we need to ensure that cerebral blood flow is present, and we do not want to drop the blood pressure too quickly. Think about the patient who's had a stroke. The majority of these patients live or have been living with a very, very high blood pressure, or at least an elevated blood pressure. And the brain, in the healthy brain, has kind of gotten used to that elevated blood pressure. And if they come in and you all of a sudden just drop that blood pressure to a normal value, say what we consider normal, like in the 120/80 range, then this can cause the brain, which now in its stroke state cannot autoregulate very well, it can really, really drop the pressure and therefore perfusion to this ill brain. And so that would then cause even more brain cells to die because they wouldn't be getting perfused. If you're confused about this, just email me. The bottom line that you need to take home, that you need to understand, is that we don't want to drop the blood pressure very, very quickly. So would we give if the patient's blood pressure was greatly elevated, would we give an oral antihypertensive med? And the answer is no, because patients that come in with a stroke are at risk for having an impaired or altered gag reflex, and therefore these patients are placed NPO. So any medication will be given IV. It's been 45 minutes since the patient arrived in the emergency department. And the CT report indicates that there's no blood or hemorrhage found in the left hemisphere. Again, why do I say left hemisphere? Remember that this patient has had a right weakness, so that indicates that there is a problem in the left hemisphere. And then there's your repeat vital signs, and then what do the results of the CT scan indicate, and then what are the anticipated treatments? And what the CT scan indicates is when the physician that reads the CT scan says there's no blood or hemorrhage, then because the patient is displaying signs and symptoms of some kind of intracranial problem, the assumption can then be made, if there's no blood, that this is an ischemic stroke and that there is a cerebral artery somewhere in the left hemisphere that is narrowed, completely occluded. And the patho of this is that either a thrombus or an embolus, so some kind of clot moved from downstream up, or a thrombus was created in that particular artery, and it has caused a narrowing of the cerebral artery. And most of the time, this is related to plaque cholesterol accumulation. So an accumulation of plaque or thrombus or embolus will then prevent blood flow and therefore O2 from reaching the brain tissue. Now, when we've talked about FAST, we talked about the assessment piece of face, arms, and speech. So that's already been addressed. That's kind of the initial acronym that you use to assess a patient. You assess face, arms, and speech. But the T in FAST is meant to relate to time, because we know that blood cells have to have oxygen within and have to have oxygen. They cannot do aerobic metabolism, and therefore if there is a lack of oxygen, as evidenced by these abnormal findings of the assessment, that we need to restore blood very quickly or more and more brain cells are going to die. So it's really time is brain cell, because once a brain cell has necrosed or infarcted, then that brain cell will never ever come back to life. Even if blood flow is restored, once the brain cell is dead, that brain cell cannot come back to life. If the brain cell has a slight decrease in oxygen, and that's what ischemia means, a decrease in O2, not absence, but just a decrease more than what or less O2 is being delivered than what the cell wants, then if blood flow is restored, then those ischemic cells can be brought or do well. But it's once the cell has died, then there really isn't anything that can be done to bring them back to life. Now, what are the anticipated treatments if we have a thrombotic stroke? Well, you should anticipate fibrinolytic therapy with TPA. TPA is a drug that they call it a clot buster or fibrinolytic agent, and that means that clots are made with platelets and then fibrin strands form to kind of wrap around that clot and really stabilize it and keep it there. Well, we want to bust these fibrin strands. We want this TPA to eat through those fibrin strands so that therefore the clot will essentially scatter. It's kind of like a ball, a hairball. You want to be able to get those strands out and away so that you can just disband the clot. And then once the clot is disbanded, then you have blood flow will return. Now, how is it or why is it that this patient can get TPA? Well, candidates for TPA are those that come in with signs and symptoms of a stroke that occurred less than 3 hours. So as long as the patient comes in that time frame, then the patient is eligible for TPA. Well, we know that TPA is a fibrinolytic, and we know that because it's going to eat through fibrin, that also means that the patient will not be able to make other clots. So this puts the patient at a risk for bleeding, excuse me, and therefore we would not give TPA to an individual who had a recent history of trauma. In other words, let's say the patient came in and they had the signs and symptoms as our patient did, right-sided weakness and speech slurred, but they had a car accident a week ago. The physician would look at the risk factors plus the benefit to getting the drug and then would make the determination of whether this was a major trauma versus minor trauma, and is this patient at risk for bleeding. Again, this is for your information. You're not going to be tested on. You're not going to be asked, well, this patient had a car accident a week ago. Would you give TPA? No, that's a physician decision. You just need to be aware and assess that history, past medical history, and identify that to the physician as you assess the patient. We would also want to assess the patient's present clotting function, and so we would assess the INR, the PT, PTT, and of course the platelet count. Once TPA is given, no other antithrombotic therapy such as an aspirin or heparin should be given in the next 24 hours. And why is this? Well, because the patient is at risk for bleeding. And the biggest concern is that they would have a bleed in the brain. That's known as an intracerebral hemorrhage. So again, any drug, there's always a risk and a benefit. And as the TPA or before the TPA is administered, they will let the family know that the risk is an intracerebral hemorrhage or uncontrolled bleeding in other places. So how do you, the nurse, identify if your patient's doing okay as you're administering the TPA? Well, you're going to assess LOC and pupil response, and there's a specific time frame. It's very quickly that you're going to do this. And of course, if there's any changes in the level of consciousness or the pupillary response, then that would be something that you would notify the physician. Note that the MAP of 133 in our story is elevated, so an antihypertensive drug, such as labetalol, could be prescribed IV. Just realize that any antihypertensive drug is going to be prescribed IV infusion, or IV push, because this patient is not able or must be kept NPO until the gag reflex has been assessed. Now let's talk about a side note, because I asked you, or I said, what are the anticipated treatments? And I said, as long as the patient has come in within 3 to 4 hours, then they're a candidate for TPA. Well, what would make a patient not a candidate? Well, let's say somebody went to bed at night, and then in the morning, a family member found that patient on the floor and they weren't able to speak or move their right side. Well, because they were found with a deficit and it's not known when the patient started experiencing these signs and symptoms, then that patient is not a TPA candidate because it's just unknown when the event occurred, and therefore we can't ensure that this is between the 3 and 4 hour mark, and therefore this patient can't get TPA. So what are the options? Well, they would give aspirin for sure. They may or may not give heparin. Again, that's a physician decision. Well, let's talk about another scenario. What about if the patient has been diagnosed as having a TIA, or a transient ischemic attack? Again, the treatment for that is aspirin. But let me first identify what is a TIA. By definition, it is an individual who comes in with stroke-like symptoms that disappear in less than 24 hours. Now, a lot of students will ask me, well, wait a minute, a patient came in and you've got to give the TPA within 3 to 4 hours. Could that be a TIA? Well, it's unknown because we're not going to wait around for 24 hours because we have to ensure that whatever is currently in the artery and disrupting blood flow needs to be removed or needs to be dissolved. And so we're not going to wait and say, hey, let's give it 24 hours. No, we need to give that TPA very quickly. So what kind of scenario would you expect to see? Well, patients don't always come in right away when they have problems. Let's say an individual is at work and they experienced a short episode where they had this left-sided or whatever right-sided weakness, and maybe their speech was slurred, and then they kind of were debating, well, should I call, should I not? Or the family's debating, should I call, should I not? And then they do finally call the ambulance, and by the time the ambulance arrives, then the patient is fully functional. So that's kind of the scenario that you can expect to get from Dr. Reed, is that a patient did have symptoms, and then all of a sudden they disappeared very quickly, and therefore that then is identified as a TIA. Now, as far as the patient goes, this is kind of like a warning sign, because individuals who have TIAs, it just means that they have all the risk factors to have a stroke, and therefore, if they don't change their lifestyle choices or get treatment, then they can have a fully involved stroke in a later date. Now, a lot of students will say, well, is a TIA a mini stroke? And that is not the case. You cannot say that, because remember that a stroke means that tissue or brain cells have died. And a TIA means that there has been ischemia. And ischemia means that there was less O2 than the cell would have liked, but it never came to the point where the cell totally died, because that would be known as a transient infarction attack, and that's not what the case is. This is transient ischemic, which means that the brain cell went with less oxygen than what it would have liked for a time period, and now that blood flow has been restored and the symptoms have gone away. So again, don't use the term mini stroke. That is incorrect, because a stroke means the brain cells have died. TIA is transient ischemic. On this slide, it's very, very busy, but these are some signs and symptoms that really identify which side of the brain. If you have a left brain damage, and when we think about left brain, we're really talking about left hemispheric damage. These are the signs and symptoms that you can expect to identify, versus a right right hemispheric damage. These are the signs and symptoms you can identify. Now, this is a pretty long laundry list of symptoms, and some students do get overwhelmed with this and think, gosh, do I have to memorize this? And your answer is no. You will have what's known, if you haven't been told, you will be told later, I'm assuming, that you can have what's known as an exam sheet that you can take in an exam sheet. So these are some things that you can put down on a piece of paper that can help remind you, and this is the kind of information that you would want to do so, because it's sheer memorization. This is not thought provoking. This is just sheer memorization of what the signs and symptoms of a left hemispheric stroke or a right hemispheric stroke. So these are things that you can put down on your exam sheet, and I strongly encourage you to do so. If you have any questions, email me. I hope this has been helpful.